Now, the old standby was flexible sigmoidoscopy, and we'll talk a little bit about that. That has to be done every 5 years. That looks at the lower part of the colon. We used to think that 80–90% of the colon cancers were within the first few feet of the rectum, and therefore this was going to be good enough. It's not, because there's lots of them that are in the rest of the colon, and we miss too many people just doing flex sig. So then we added a baryomenema. And baryomenemas look at the rest of the colon. Well, once again, smaller polyps, it's hard to see them on the X-ray. And so, again, has to be done every 5 years. Well, virtual colonoscopy. I need to talk a little bit about virtual colonoscopy. That's the greatest and latest hot thing. You hear about it all over the radio. The University of Wisconsin is real high on it. What we're trying to do is figure out a way to get more people to do this examination. And some of them are afraid of the endoscope, which is the reason that we're here today, so I can talk about this and hopefully break a few myths about it. So the virtual colonoscopy is just simply an X-ray. It's a CAT scan. Actually, it's 2 or 3 CAT scans by the time you go through the machine enough. It still has limitations. You cannot get out of taking the preparation, which most people tell me is the worst thing about doing the colon exam is the prep. And we'll talk about the prep later. In fact, it has to be even cleaner than a colonoscopy. So it's a little more miserable in that direction. It's got an advantage that you aren't sedated, so you can go have it done, you can go home, you don't miss a day of work. That is an advantage. But a very significant disadvantage is there's a very high rate of false negative. It's about, if you have a polyp about the size of a small grape, there is a 10% chance you can't see it on this exam. Now, a small grape, to me, in colonoscopy is huge. If it's about the size of a lentil bean, there's at least a 30 to 35% chance you aren't going to see it on this examination. So once again, you have to have this exam every 5 years. So the gold standard is colonoscopy, still. And that's where we can specifically and carefully examine the inside of the colon. If you don't have a family history, if we don't find any polyps, this only needs to be done once every 10 years. Statistically, that's a very safe way to go. So I have a little show and tell here, just to show you the equipment. We have 2 rooms we call the endoscopy suite. We have this equipment there. It is much more sophisticated. This is our travel cart. If we have to run to the intensive care unit or go to surgery, we grab these carts and we take them down to do it. But so this to suffice to show you what the equipment that I need. There's a computer. This is a computer and light source combined. We have a printer for pictures. In my room, I have another computer and printer, because my reports, I don't dictate them. I generate them immediately upon completion of the examination, and it's a body of the description of the entire procedure embedded with the actual photographs I take. Those are completed within about 5 minutes of the exam, and then I send them to the doctor that day. So I have an extra machine. Over here we've got the monitor. Now up at our endoscopy suite, we've got the nice brand new flat screens. Well, we haven't spent the money yet, but this is what I look at, and this is where the picture shows up of the inside. And then we've got our various snares and things like that. This is the colonoscope itself. I took this to Rotary one time. I think half the club fainted. Because you hold it up like this, and people realize, and then they worry that the whole works goes in. Well, no, this end hooks into the machine, because you got to get your light from somewhere, right? This is the business end right here, with all the little markings on them. It's kind of neat. It reminds me of Star Wars, and I don't know if anybody remembers the garbage compactor scene. But as you can see, I can direct this deal, make it move wherever I want to make it move. And that's how I thread it through the colon. And then there's a port here. This is where I can put my little instruments, my biopsy forceps, my snares. I have a little probe that can cauterize and stop bleeding. We've got little graspers that can grab people and things that like nickels and pills and pens and other things that we tend to find. Fortunately, most of those are out of the stomach. It's a smaller instrument I use for the stomach. So, looking at this diagram, we talked about flex sig. See, flex sig stops about here. And with that long tube, I go all the way to where we call this the cecum. And the goal is to always get there, so you know that you have examined the whole colon. Now, I'd like to tell you folks something, though. You always see these pictures. You know, we have the rectum, then we got this, what they call the sigmoid colon, this little S curve, and then the splenic flexure, and it goes straight over here. That's hepatic flexure, ascending colon, the cecum. This is fiction. There isn't a colon in the world that looks like this. I mean, first you go here, then you got to do loop-de-loop around here like this, and then this kind of wiggles around a little bit. Then sometimes this makes an actual 180-degree circle, 360 degrees, and this one maybe down here like this, or maybe up here like this, and then this makes a few little twists and turns. And sometimes the cecum is down here, and sometimes it's over here, and sometimes it's over there. That's why it took me a year and a half to figure out how to do this. So it's not as simple sometimes as it may look. So what the heck am I looking for? Well, we want to find the polyp before they become cancerous. We find early ones. And there's no symptoms. That's very important to understand. There are no symptoms of polyps, which is why we tell people to get screening and why symptoms don't help us prevent cancer. This is a little polyp. I like those the best. You know, small divots when I'm done, less complication, easy to take out. Here is a bigger one. And this isn't even big. I mean, I've seen some the size of ping pong balls. Now, there's something I really don't want to find. That's colon cancer. You see how irregular, look how ugly that looks. All the blood vessels. This back here is normal. It's kind of hard to see in this light. But this whole shooting match here is cancer. I don't want to find that. All right, you got to come sooner. So how do I get them out? What do I do? Well, I told you I had a little port and I could stick stuff through there. So here, what we need to do is clean the colon out. The prep is very important because the better I can see, the better examination you're going to have. So I tell folks to have a clear liquid diet for a couple of days. I have a personal history of polyps. That's what I do before my exam. A couple, 3 days, I drink soups, and I just kind of, because my theory is the less you have in you, the less you have to clear. Now, I had one fellow that took triple doses of the prep, and I figured out that he actually, the night before, had his, what he said was his last meal, a huge, beef roast, and a laxative the day before your preparation starts. So let's, for example, let's say you're going to have your exam on Monday. Saturday night, just take a light laxative. Just get started. It'll make the prep go so much easier. Now, there's a liquid prep. That's the famous liquid preparation. It's called Go Lightly or Colite, various brand names. It's got some advantages in it. It works very nicely. It's extremely safe. It's a liquid that's not absorbed into your body. There are very, very few side effects, except taste terrible. Some people get terribly nauseated and get a lot of bowel cramping from it. But it's safe. Then there's what we call the pill preparation. Now, if you're a good pill swallower, my patients like this about 3 to 1. Now, you do get 32 pills. Now, the thing is, we do have to talk a little bit about phosphorus. You may have heard over the last few months the FDA took Fleet's phosphorus soda off the market. The reason they did that is because Fleet's phosphorus soda, those little bottles, It's a very, very strong laxative and purgative, we call it. There were a lot of people who didn't want to drink all this stuff. Whoops, oh dear me. Didn't want to drink all this stuff, okay? So they would just, and they didn't want to take all these pills, so they wanted 2 little bottles of Fleet's Fuss soda. And they were led to believe they could just drink that, take a little sip of water, that's all they had to do. Well, the problem is it sucks all the fluid out of your body, fills your kidneys with phosphorus, and people have developed kidney failure. Now, mostly not for colons, by the way, but mostly happened in people just for using it as a laxative. So the FDA said, no, Dice, we've got to pull that off the market. We can't have that as a non-prescription item anymore. The pill prep does have phosphorus in it, but it is meant to be used with lots of hydration. Water, lately I've been telling people to use Gatorade or some of those new electrolyte waters. And if you hydrate yourself, there has never been a case of kidney failure with this prep. It will have a black box warning on it, but many of the medications that we prescribe have those warnings. What a black box warning means, it alerts the doctor, tell your patients, be careful, this is a possibility, just be monitored. Now, there are some folks I won't give it to. It's not so much age-related. They used to think it was age-related. That's changed. It's more related to how healthy your kidneys are and how, if you have diabetes, for example, or various medications that you're taking that might put the kidney at stress. So I will always go over that before